Well, my task in this topic is to share with you my philosophy and the techniques in dealing with a high-riding hip. So in 1973, John Chanley warned not to attempt the operational reconstruction of a non-reduced congenital dislocated hips. This is definitely wrong today, but however, this is still worth listening to. We had a very bad time when we began to reconstruct this kind of disease. We dissected radically and extensively. We couldn't reduce the hip. The bone loss, the blood loss, the volume is quite high. So what we learned, lesson number one is a total hip arthroplasty is mainly a soft tissue procedure. If you are dealing with a high-riding hip, this is extremely true. What we learned is, actually there are two sleeves, two soft tissue sleeves around the hip joint. So the outer layer is mainly composed of deep fascia. The deep layer is mainly composed with capsule. And these two layers interact. So you can't reduce the hip if you only radically release the inner sleeve. You have to interplay with these two layers. So to us, sub-trochanteric shortening is definitely needed. The other important issue is about the gluteus medius. So as we all know, for a high-riding hip, the greater trochanter is always stays in the posterior part of the proximal femur. If we are going to bring the proximal femur down, why keep the greater trochanter stay in the posterior part? You will definitely tighten the gluteus medius. This will make reduction impossible. Otherwise, you have to do radical soft tissue release. So repositioning of the greater trochanter is definitely needed to optimize abduct function to properly control the length and the tension of gluteus medius, and also to control the orientation of the contracture of this muscle. Otherwise, you may encounter this catastrophic complication. I'm going to touch a little bit of details. How do we reposition the greater trochanter? I will talk about it later. Lesson number two is a total hip arthroplasty for a high-riding hip actually is an art of compromising. Because high-riding hips present quite a broad spectrum of complexity. The socket is shallow and is definitely deformed. It has increased anteversion and quite a narrow canal in the proximal femur. And obviously, the abduct function is compromised. It's extremely difficult for you to achieve leg length equidistance. Just as I told you, we had a very bad time. The complication rate is as high as to, let's say, 35%. We have split the proximal femur, and then thus we have the so-called floating trochanter. We had split both proximal and the distal part of the osteotomy. We have the stem loosening, just like this. So what we learned is we have to compromise. Let's say this is a patient of mine. High-riding hip underwent 2 or 3 times of operation. One important issue you have to compromise is you can't put the cup anatomically first, because this patient underwent quite several times of the surgery. It's heavily scarred, and this hip is quite stiff. If at the beginning you put the cup here, it's highly impossible for you to have difficulty to reduce the hip. So for this kind of a hip, I will not hesitate to do sub-trochanteric shortening osteotomy. Then I will put my child in, and I ask my assistant to distally check the femur. Then I will find how distally I will put my socket in. So this is a kind of compromise. Lesson number 3 is all high-riding hips are not the same. So if we are going to reconstruct a high-riding hip, we have to position both the cup and the stem properly. The primary stability and the biological fixation depends on the positioning of the cup and the stem, and we have to pay enough attention to the offset to maintain joint stability. This depends on the position and the orientation of the implants. So this is a study we did, and we published this in CURR. So we found generally we can divide congenital highly dislocated hips into 2 groups. One group with contact between femoral head and the iliation. The other type is the femoral head is floating within the musculature. So there are morphological differences. Usually, if there's no pseudoarthrosis, the femur will migrate much more superiorly, and the canal will become much narrower and more stovepipe-shaped. Also, we developed a software to calculate the bony coverage of a metal shell. We simulated with more than 100 high-riding hips. What we found is we can divide the cup into anterior half and the posterior half. If we put the cup with 15 degrees anteversion, we will left at least 25%. Even you medialize the cup and posteriorly migrate the cup, you will still have 25% of the porous coated cup uncovered with bone. This will lead to impingement between iliacus muscle. And also, this will definitely decrease the bony contact and thus decrease the area which lead to biological fixation. So what we found is you can medialize the cup and you can posteriorly position the cup slightly. And if you put the cup with 30 degrees of anteversion, you will achieve much satisfying bony coverage. By this, you can successfully avoid impingement with iliacus muscle, and you can maximize bony coverage. So in our practice, the so-called combined anteversion is of great importance. You have to sometimes, put the cup with a little bit more, let's say 30 degrees or 35 degrees anteversion. So with a modular stand, you can decrease the anteversion in the femoral side. So you still get a quite satisfactory combined anteversion. Lesson number 4 is we found a high-riding hip is frequently associated with varus knee, if not always. This is a patient of mine. I did a bilateral to the hip for this girl. You see, this girl has quite a severe varus deformity of bilateral knees. This kind of varus knee, which is associated with dysplastic hip, may lead to ipsilateral knee pain, instability, and will definitely increase the risk of dislocation of the hip. So you have to put the varus knee into consideration. So you can use a high offset stand to medialize the femoral head and thus medialize the mechanical axis. If the varus deformity is severe enough, let's take an example. This is a patient referred to me. She has high riding hip and got his hip replaced. Obviously, the work is not properly done. However, the hip is asymptomatic. But this patient complains of knee pain and instability. What I have done is to do the supracondyle osteotomy. Once I finished this kind of osteotomy, the pain is gone and the knee is much stable. So to us, the shortening osteotomy is quite helpful to eliminate leg length discrepancy. And with this kind of shortening osteotomy, we never have a patient with nerve palsy. So I have to confess we do at least 20 to 25 high-rating hips a year. So by this kind of sub-trochanteric shortening and derotating osteotomy, it helps us to reconstruct the cup anatomically, to balance the leg length and avoid neurovascular complications. However, the complication rate of this kind of osteotomy is quite high. The trick is you have to control the osteotomy level. So you download it a little bit, you can do prophylaxis, a wiring, you can use back table technique to assemble the leaf and the stem. So I'm not going to touch the details of this osteotomy. Because time is limited, I have to skip some slides. Sorry. So in summary, all high-riding hips are not the same. With the reconstruction should be individualized. So different surgical procedure and different geometry of prosthesis, either modular or monoblock, has to be prepared to reconstruct the proximal femur. Repositioning of the GT is important to optimize the gluteus medius function. Sub-trochanteric osteotomy is a very useful tool. So this is what I learned since my childhood. Victory in war is not repetitious, but adapts its form endlessly. A high-riding hip presents a combination, variable combinations of complexities and difficulties. So I thank you for your kind attention.
Well, we are going to have the discussion at the end of the presentations. So I ask